Our next presenter is Dr. Kenneth Langa from the University of Michigan. Dr. Langa is the Cyrus Sturgis Professor in the Department of Internal Medicine and Institute for Social Research. He's also a research scientist in the Veterans Affairs Center for Clinical Management Research, and he is also an associate director of the Institute of Gerontology, and all of these positions are at the University of Michigan. Dr. Langa's research focuses on the epidemiology and costs of chronic disease in older adults with an emphasis on Alzheimer's disease and other dementias. He has published more than 250 peer-reviewed articles on these topics and is currently studying population trends in dementia prevalence and the relationship of common cardiovascular risk factors, as well as acute illnesses such as sepsis and stroke, to cognitive decline and dementia. We would like to welcome you, Dr. Langa, and we look forward to your presentation. The floor is yours.
Great. Thank you, Eric.
We can't hear you, though. I think you need to turn your microphone on.
I'm unmuted here.
No, we still can't hear you.
We can hear you.
We can hear you.
Okay. So let's see. Everyone hearing me now?
Yeah.
And seeing my slides? Everything good?
Yeah.
All right, great.
Whoops. I'm sorry, I can hear you. I have my
all right.
off. Okay,
Great.
You're on.
All right. Thank you, Eric. And yes, thanks for this invitation. And I'll try to keep up the high quality of the presentation so far. It's been a great morning with the other presenters. So let's see. My slides are not advancing. Let's see. There we go. Okay, here are my disclosures. I get grant support from NIH and from the Alzheimer's Association. I have no financial support, have not received financial support from for-profit companies. And what I'd like to do in the next 30 minutes or so is I'll provide a bit more background and some papers that have been done looking at economic and racial and ethnic disparities in health and brain health. Specifically tell you about the main NIA-funded study that I've been involved with that provides data, publicly available data for the study of racial disparities in health and brain health. That's the Health and Retirement Study, or HRS, the Aging Demographics and Memory Study, ADAMS, which has an important Duke connection, which I'll tell you about when we get there, and then the Harmonized Cognitive Assessment Protocol, or HCAP. ADAMS and HCAP are two sub-studies of the HRS focused on cognition and dementia. And then just a bit of information about how researchers can get access to all of these data. Just to, again, remind ourselves of some of the complex pathways that folks this morning have been talking about and that we're trying to study in understanding disparities. Again, sort of starting here with biology and geography, social institutions, racism. Again, the folks this morning have done a great job laying out some of these issues. Obviously, one of the challenges of studying causal pathways is the overlap, especially in the United States, of socioeconomic disadvantage and race and gender differences. Also, again, some of the pathways that we've talked about already so far, important issues in terms of chronic stress, possibly leading to inflammation, chronic levels of pro-inflammatory states that might affect health in general and brain health in particular. Education, obviously, extremely important in thinking about dementia risk and cognitive reserve and resilience. Quality of education differs significantly across race in the United States. Again, the responses that, again, many folks have already talked about, complex, interacting, overlapping, leading to the key outcomes, again, mortality, disability, including cognitive decline and disability. Just one highlighting, and again, I think both Brian and David highlighted this a bit, the important overlap between cardiovascular disease and Alzheimer's disease. You all know that physiology and evolution have shown us how important blood flow is for the brain. It's only about 2% of body mass, but gets about 20% of all of the blood that the heart pumps. Overlap in risk factors, again, talked about already: hypertension, diabetes, high cholesterol, obesity, important ApoE4 as a risk factor too that Brian talked about so well. Having more vascular risk factors in midlife has been shown to be associated with more amyloid protein in later life. So important overlap and interaction among or between cardiovascular disease and Alzheimer's disease. And again, I would put this as one of the complexities among many. David Bennett and team have published lots of the important work showing us how important the overlap of multiple pathologies is in the brain and as a leading to cognitive decline in the community. So just as one, why thinking about this is important in terms of disparities, specifically the risk or the overlap between cardiovascular risk and Alzheimer's risk or dementia risk. These are data from NHANES that show top line here, or the dark line is folks at or below the poverty level, middle income, high income, looking at time period from about 2000 to 2015. And these are trends in cardiovascular risk factors. Looking at the middle panel first, this is systolic blood pressure. Note the significant improvement in blood pressure control in high income individuals between 2000 and 2015. Also in middle income, pretty much flat for those at poverty. Similar story for smoking. Look at the huge difference in smoking rates between those in poverty and high income. And again, there's been further declines in smoking cessation among high income adults during this time period, not among middle income or low income adults. And then overall, this is sort of an overall risk scale, putting together a number of different cardiovascular risks on the left panel. Again, the general important issue of improvement over time for middle and high income individuals, no or even worsening of cardiovascular risk overall for those in poverty. Also, again, huge increase in disparity in life expectancy in the United States over the last generation or two. These are data from the Health and Retirement Study and a National Academies report that came out a few years ago. And what's shown here is the life expectancy for men at age 50. So these are the number of years expected to live at age 50, so 26.6 years. This is lowest income quintile, lifetime income, highest income quintile here. This is for men. The pattern for women is very similar. And again, the key issue here to note is that back among the older cohort, those born in 1930, there was some patterning of life expectancy by income. Again, high income individuals, high income men lived about 5 years, a little less than 5 years longer than low income individuals. But that huge disparity, or that disparity, increased significantly. And among the 1960 cohort, there's now about a 13-year difference in life expectancy on average in the United States. So huge, huge growing, important disparities in health in the United States. Turning from mortality just to some health conditions. This is a bit of a busy slide. These are, again, data from the Health and Retirement Study and our English partner study, the English longitudinal study of aging. ELSA data in the orange line here, the orange circles, HRS or the United States data in the darker circles. And what these are prevalence rates by income decile. Again, lowest income individuals on the left, highest income on the right. Two main punchlines here that US health is worse on average, higher prevalence of all these conditions among those in the United States compared to England. And the main difference across country is in the low income deciles. So again, high income individuals in both countries doing better. The main disparities are among those in the lower part of the income distribution. And then finally, David Bennett mentioned cytomegalovirus infection and sort of the patterning by race. We find similar disparities in the health and retirement study. You can see here, these are antibody levels to cytomegalovirus among Black, Hispanic, and white individuals in the United States. This is a paper by Duchovny and Noppert that came out in AJE last year. And again, suggesting sort of more pro-inflammatory state among Blacks and Hispanics. And as David said, one of the potential causes for disparities is just higher levels, even if there's not an interaction effect by race, just a higher level of the risk factor among those, among Blacks and Hispanics. All right, turning specifically to studying brain health and disparities in brain health in the HRS. Again, just to sort of remind ourselves or review some of the both the big picture data as well as potential pathways. Many studies have shown at 1.5 to 2 times greater risk for dementia among African Americans as compared to whites. Latino results vary across different Hispanic groups. In the HRS, Hispanic older adults had similar cognitive function to non-Hispanic Blacks in a number of studies that have been done. And again, we think these the pathways toward these disparities are multifactorial. They're likely happen across the life course. We haven't talked about parental education or parental well-being, likely important, childhood health, racism, stress, education. Again, lots of these social factors, almost certainly extremely important. Having data on these various social factors, important to try to disentangle these issues. Talked about the disparities in cardiovascular risk. Pollution and environmental exposures are getting more study and are likely important. And then Brian again talked well about the issues in potential differences in effect, for instance, in ApoE across race. These are a study we've done with the health and retirement study looking at dementia risk and trends in dementia risk between 2000 and 2012. For now, just wanted to again show what sort of the general magnitude of these differences that we found in the health and retirement study. After controlling for age and education, still significant SES and racial differences in risk. About again, we found about more than 2 times the odds of dementia among Black individuals in the HRS compared to white. This was a paper also, again, using HRS data. My colleague Eileen Crimmins and Mark Hayward have been doing a lot of great work to sort of put all of the information on life expectancy and risk for cognitive decline and dementia by race and education level using the health and retirement study data. And again, the sort of red highlighted bars here show important punchline of dementia-free life expectancy and how that is significantly lower for Blacks compared to whites. So both lower life expectancy overall, but also more likely to spend more of the remaining years with dementia. So important disparities, both in life expectancy, but also life lived without dementia. All right, so in the final 10 minutes or so, just to give a bit more information about what the Health Retirement Study is, what are the data that are available, and how to get access to them. HRS has been now going on for 30 years, actually a great investment by the National Institute on Aging and the Social Security Administration, following about 20,000 adults 51 and older across the United States, except for Hawaii and Alaska. And performed again here at Michigan. David Weir, my colleague here, is the principal investigator. We collect lots of different kind of information that, again, we think is important for trying to understand these complex pathways that we've been talking about. We do interviews both face-to-face and by telephone, and now actually also by the web, a web interview. All of the data are publicly available. You can go to the HRS website, as I'll show you, to download these data. Because of that, there's been lots of publications and lots of folks who use the data. Here's a general list of the domains of data collection that we do. Again, we do a survey that takes about 90 minutes to 2 hours, but then we also link the data to administrative data. So you heard about Medicare linkages this morning. We are linked to the Medicare files for these folks. The National Death Index, we have a subsample of folks from the Veterans Administration using their healthcare data from the VA, and also, again, the Social Security Administration. The biomarkers that we've collected, we started collecting them in 2006 with a dried blood spot, but now do a venous blood collection, first done in 2016. So have lots more in the way of biomarkers that can be used to look at some of these pathways that we've talked about. We were supposed to do another round of blood collection in 2020, but got canceled because of COVID, hoping to do that now again in 2022 in the wave that's about to start up. And then we also have genetic information on a large number of people in the sample too. This is the cohort design, just to give a sense. Again, started in 1992 with a cohort of just 51 to 61-year-olds, and then older cohort added later. Since 1998, the HRS has been, we've filled in the age range and has been representative of the 51 population. And then every 6 years, we backfill the sample with another 51 to 56-year-old cohort. Did that in 2016, and we'll do that again in 2022 for the early Gen X cohort born 1966-71. There's also NIA and has made great investments in collecting similar data on aging in countries around the world. There's about 35 countries that have collected data in a similar way to the Health and Retirement Study. You can see the map here. I'll tell you more about this Gateway to Global Aging website, where you can get the information from all of these different studies, and also sort of compare questions and data across the studies. These are some of the key information for tracking brain health in the HRS. We do the modified ticks at every wave. You can see the sort of cognitive testing done here, animal naming, number series, and these other cognitive assessments. Also collect information from proxies, as you all know, who work in this area. Important to have information from proxies as people's cognition declines and they're no longer able to participate in the cognitive assessments. And again, lots of the information on the protective and risk factors that we've been talking about. Cardiovascular disease risk. I didn't mention that we measure blood pressure and do lung testing and balance testing when we're in people's homes. Acute medical events can be obtained through the Medicare linkage. Again, the genetic information and other information here. As I mentioned, residential history and neighborhood characteristics. There's been sort of growing data put together on geography and things like pollution levels and noise levels and crime and availability of parks and walkability and things like that that can be linked with the HRS. The first sub-study that we did in the HRS was, again, the ADAM study, which Brenda Plassman at Duke led the cognitive assessments and the field work for ADAMS. Wouldn't have been done without the Duke team there that Brenda led. We assessed, Brenda and team assessed 856 HRS subjects in their home, did a big neuropsych assessment, APOE assessment, and then consensus diagnosis of CIND or dementia done with Brenda and team at Duke. Our more recent sub-study on dementia in the HRS is the HCAP. In initial field period in 2016, the plan was to do follow-up in 2020, which got delayed also because of COVID, and now planned for 2022. A larger sample with the less intensive data collection. We do about an hour's worth of cognitive testing and a 20-minute interview with an informant. You can see the number of Black and Hispanic respondents. So larger numbers hopefully will be able to support additional studies of racial and ethnic disparities in cognitive decline and dementia. There's been a lot of work by a number of different groups using the ADAMS data and the gold standard diagnoses that Brenda and team developed to then create algorithms to get an idea or a probability of dementia for the rest of the individuals in the health and retirement study. And for those of you interested in using the HRS data, this work by Giannattasio and Melinda Power, Maria Gleamore have been, they've done lots of important and careful work on lining up and how to use the data in the HRS to do these kinds of classifications. One study, just to give you an example of that, led by Melinda Power, was published last year in JAMA Neurology. So again, using the combined ADAMS and other data within the HRS, looking at trends in dementia between 2000 and 2016 in general. They did find a decline in dementia prevalence in the United States that others have found with the HRS and other studies, Framingham and other studies, both in the United States and elsewhere. But interestingly, no change in the Black-white difference in dementia prevalence. So again, between 1.5 to 2 times higher rates of dementia for Black individuals compared to white individuals during this time period. Then finally, another important issue, and again, the prior speakers have touched on this, the importance of generalizability or getting data on more representative samples, African-American and more African-American and Hispanic individuals rather than sort of volunteer samples. This was a paper, again, led by Giannattasio, comparing results from ADNI, I'm sure most of you know, the Alzheimer's Disease Neuroimaging Initiative, versus ARIC, the atherosclerosis risk in communities. This is a clinical volunteer sample. This is a population-based sample looking at the relationship of some key predictors to outcomes. So the way this slide is set up, this is the outcome here, many mental state, poor performance on the MMSE, poor performance on Boston naming, and then this is amyloid positivity done using amyloid PET scans. So the key patterns to notice here are that, for instance, amyloid positivity much more significantly related to poor cognitive function in ADNI compared to the community-based studies. APOE4 much had much stronger relationship to amyloid positivity in ADNI. So again, the concern is that can the results from studies like ADNI or other RCTs that use volunteer samples that are often more educated with very few Black or Hispanic participants. Can we generalize findings from those studies to the community? Here, just to give you a general sense of the sample sizes by race and ethnicity in the HRS. This is from our 2018 wave. So you can see about 3,600 Black individuals, 2,700 or so Hispanic individuals, and then again, wide range of age, education, and we also have lots of socioeconomic and wealth information. NIA is also investing even more in trying to expand opportunities to study racial disparities using the HRS in our next screening in 2022 this year. As we head into the field, we'll be trying to enroll or have a goal to enroll an additional 2,000 African American and Hispanic respondents, again, to increase the power and ability to do these kinds of studies of complex pathways across race and economics. Again, all of these data are available at the HRS website shown here. Also have a separate website for the HCAP studies. I didn't mention that there's about 13 of the international studies in the HRS are also doing this HCAP additional data collection on cognitive impairment and dementia. The Gateway to Global Aging website is where to go for specifically for international data. So to wrap up, again, racial and SES disparities in brain health are significant, I'd say huge, and persistent in the United States. Complex causes that likely overlap across the life course and interact, leading to these disparities. Therefore, you'd like to have longitudinal data with representative samples to really get at these complicated pathways. And again, we think the HRS, ADAMS, and HCAP are good places to get those kinds of data. Again, just to thank the NIA for their support, as well as the Social Security Administration for supporting the HRS. And that is it. Great. Thank you.
Okay, so Dr. Langa, thank you. That was very informative. I hope a whole lot of people who haven't been using the HRS will be inspired from your presentation to do so. I just checked on the web to see if there were questions. Right now, there's no questions. So